Hi, good afternoon, everybody. Thank you very much for spending your lunchtime with me. Over the next 20 minutes or so, I'll be talking to you on this very, very common topic, which is knee pain. Now, knee pain, a lot of people have, right? From young people playing football, then kena knee pain, to your old ladies who are walking bow-legged. Remember, your akong, your amas who have knee pain when they go up and down stairs. These subset of patients have what is called a degenerative condition of the knee or wear and tear condition. And this is what we are going to be focusing on today. All right. So, like I said, knee pain, very, very common. Also, many, many causes. And we have so many names for all this condition that it's not surprising that a lot of people are confused over what we are talking about. So, commonly, osteoarthritis is mistaken for things like gout, rheumatism, and even osteoporosis. Before I go on to talk about what osteoarthritis is, I will briefly talk about what these conditions are. Gout essentially is a condition of metabolism where there's an accumulation of crystals inside your body, in your joints. It presents very much like arthritis, but it's usually a lot more painful. Your knee gets more swollen, there's redness, and its onset is a bit more acute, so it hits you suddenly. So if you have those conditions, more likely gout, especially if you have a family history of gout. Rheumatism is a whole different kettle of fish. Although the end stage is that it results in cartilage damage just like osteoarthritis, it is actually an autoimmune condition where your body attacks itself and destroys some of its own cartilage. Osteoporosis and osteoarthritis very commonly mistaken because they all have the words osteo inside there. So essentially, osteoporosis is a condition of the bones. So a lot of my patients ask me, "Hey doc, I got knee pain, can I take calcium or not?" It's not really related. You take calcium for osteoporosis, but calcium not really effective for osteoarthritis. So what exactly is osteoarthritis? Now, if you have eaten chicken drumstick before, right, you see the end of the chicken drumstick or this shiny white thing, that is the cartilage inside your joint. It is this cartilage that's responsible for your joints being able to move smoothly and freely without any pain. All right. So if you see on this cartoon on the left side, you can see what normal cartilage looks like. Nice, shiny, and covers the entire joint. But over time, as the cartilage starts to get damaged and starts to get worn out, then you start developing little cracks and little holes inside the joint. Initially, only affects one part of the knee, but subsequently, as things become more and more worse, or it can affect the entire knee joint as well. All right, so that is osteoarthritis. Now, why do people get arthritis? All right, the most important factor is age. All right, it is a wear and tear condition. The more you use your knee, the older you are. Then there's a more chance that your knee wears out and you start developing symptoms of osteoarthritis. Unfortunately, just one step back. So as you cross the age of 65, 1 in 5 people above the age of 65 will have knee arthritis. So very, very commonly in our elderly friends. Women, unfortunately, also have a slightly increased incidence of knee osteoarthritis. And there are many reasons for this. Number one is that the cartilage in women tend to be thinner to start out with. So as time goes on, it wears out a little bit faster. And we know that menopause and hormonal withdrawal also has an effect on arthritis and cartilage health. So unfortunately, women do have a higher incidence of arthritis. But you can't choose your age and you can't choose your gender, right? But what you can definitely choose is your body weight. And we know that among the modifiable risk factors, obesity is the most important one. If your BMI crosses 30, which is the definition of obesity, then your risk of knee arthritis just skyrockets. And it's a very, very simple physical principle. If there's more stress and more weight that goes through your cartilage, they degenerate faster. Also, if you have previous injury, like that's what I was talking about just now, you play football, play basketball, and you twisted your knee and you have injury, then it's quite important that you see your doctor early to get treatment because some of these injuries result in abnormal stresses passing through the knee and that can lead to accelerated osteoarthritis. So what are the symptoms of arthritis? All right. So pain, swelling, stiffness, and deformity. Pain initially happens when you're doing vigorous activities, right? So maybe when you're running or when you're playing sports. But over time, these symptoms worsen and you will find that even normal walking on even ground, flat ground may cause you pain. a typical progression of pain in knee osteoarthritis will be a low level of pain on most days. But occasionally, these pain spikes up to, let's say, a pain score of 6 or 7 out of 10. And then with treatment and with rest, this gets better. After a couple of days or weeks, then you go back to your baseline level of pain. But gradually over time, this low level pain becomes worse and worse, eventually until this pain can affect your function and your daily activities of living. In a lot of patients, we also find that they have problems negotiating stairs. Initially, when going downstairs, then sometimes going upstairs, which is why sometimes you see upstairs our older patients, instead of walking steps just like how we do with taking one step at a time, they go down either sideways because that places a lot less stress on the knees, or they put both feet on the steps before they transition to the next step. Squatting also becomes problematic. Swelling is quite a common feature of osteoarthritis. So these, just like the symptoms of pain, can come and go. Right. So occasionally your knee gets swollen like a basketball. Then once you rest, you elevate your leg for a while, it comes out again. All right. Remember just now when I was talking about gout, I did mention that gout can give you swelling as well. The difference between this and gout is that the pain and the swelling in gout tends to be a bit more sudden, acute, and a lot more painful. Whereas the swelling that comes on your knee osteoarthritis is a little bit more insidious and slower. With all this pain and swelling over time, you develop two things, all right? Number one, you get stiffness in your knee. The amount that you can bend your knee is no longer as much as what you can in the past, and your knee becomes more and more stiff. Sometimes this stiffness occurs early in the morning when you first wake up after you've slept the whole night, where all your soft tissue had time to contract. So after you walk a few minutes, it gets a little bit better. In the end stage, then your knees start to become bigger. Very, very commonly, we see what is known as bow-leggedness, or what we call a varus knee, all right? So exactly like you see this old man in this picture, okay? Walking around like a cowboy leader. But occasionally, the knees also flip outwards. They go to the other way around, called a valgus knee, all right? And in some patients, you get one knee that is bent inwards and one knee that is bent outwards, almost like the wind is blowing them to one direction like that. So that's called wind-swept knees. So these deformities are very, very common in patients with rheumatoid arthritis. So if you have all the symptoms that I just mentioned above, how do you know when you need to go and see a doctor? Because knee pain, like I said, knee pain is very common. A lot of us, knee pain 1 or 2 days after that, then it gets better already. So if the pain is affecting your function, for example, you cannot go up and downstairs. You want to go downstairs to the coffee shop to go and buy coffee, you are screaming already. You will need to come and see the doctor. If the pain is lasting for more than 2 weeks, and especially if it doesn't get better when you take simple painkillers prescribed by your family physician, then you should also come and see a doctor. The last reason to come and see us early is when you have very, very bad deformities of the knee. Especially, when you walk, you find your knees very, very unstable. You're rocking left and right because of the deformity. Then again, you should come and see a doctor. When you do come and see us, then what is the aim of treatment? It's very simple. Orthopaedic surgeons deal with things very, very simply. We just want to restore you to the function that you previously had and that you desire. So some people want to go skateboarding like that. Most people, they just want to be able to walk up and down stairs, go and do the activities of daily living, go to work without any pain. So that is what we want to do. Treat your pain to restore your function. Okay? So very commonly, people ask me, Doc, what can I eat to make my pain better? There are a lot of medication out there. All right? And because these are supplements, they are not regulated by medication. There are many, many types of I put many things inside there, right? Many, many different combinations, and not always regulated. So it's very, very tough to say whether these things work or not. But there are a few that stand out that we know over the period of years through research that they do work. All right. Glucosamine has been very, very popular over the past 10, 15 years, right? We have been giving them like candy for knee pain. Initially, when it first came out, we thought this was God's gift to knee arthritis because initially it seemed to work very, very well. But I think with research over the years, we find that the result may be a little bit more modest than what we think. Generally, because there's not much side effect and they're fairly cheap, most doctors will still let you try glucosamine for a short period of time. but we find that the effect of glucosamine not to be as strong as what we thought they used to be. The next thing that's coming up is collagen, right? Collagen, very popular. A lot of people take it for their knee, but very, very commonly people also take it for their skin. So, unfortunately, the formulation for your skin and for your knee is a little bit different, all right? So you do need to take unhydrolyzed or undenatured collagen for your knee condition. Collagen, while it is a building block for your cartilage, also has an immune function. Taking these collagen helps the body recognize these collagen molecules so that it doesn't attack itself and destroy the cartilage. So what I just described, glucosamine and collagen, belongs to this group of supplements that are the building blocks for cartilage. And the purpose of taking all these things is try to preserve your cartilage and prevent degeneration. But there's a whole other group of supplements out there that helps to decrease inflammation, all right? And a lot of people are taking these just to reduce the inflammation generally inside their body. So we have things like turmeric, ginger, and even capsaicin. Capsaicin, not taking orally for reducing inflammation. You can apply it topically onto your knee to help relieve pain. So everything added together with the collagen just sounds like a very good recipe for curry chicken. But curry chicken doesn't help you with your knee pain. Okay. Another thing that's quite important is vitamin D now. All right, we know that with vitamin, right? So just now I did say that osteoarthritis and osteoporosis are different conditions. But let me correct myself a little bit now by saying that there is a little bit of link between weak bones and osteoarthritis, because we find that in patients with very, very weak bones, especially in patients who are deficient of vitamin D, there are small cracks that can develop underneath the cartilage in the bone, and that leads to traces support for the cartilage, and you can get pain as a result of this lack of support for your arthritis. So vitamin D, while traditionally used to treat osteoporosis, can also be quite useful to arthritis. But generally, these are two very, very different conditions that are treated separately. Okay, what about injection? These come in many, many different flavors, all right? People make their own cocktails and different type of injection. But generally, they fall into three groups, okay? First one is steroids. Steroids are a very, very bad name. People think that once I take steroids, I am this muscle man or bodybuilder who's abusing steroids. No, steroids are very, very important medication for doctors, all right? And we use them to reduce inflammation. And when used correctly and when used appropriately, they don't go to the rest of the body and cause side effects, all right? When injected into the knee, they reduce the inflammation. It helps to reduce your pain and symptoms quite quickly. Having said that, long-term use and frequent use of steroids can lead to problems, including infections and destroy the cartilage itself, paradoxically. So we limit the use of steroids to patients who are maybe not fit for surgery, not fit for other forms of treatment, or patients who are very, very old who don't want surgery. Hyaluronic acid is another interesting. It's this gel that we can inject inside the knee. A lot of people think that this is like going to the car workshop and changing oil, every 3 months go for a knee injection. No, please, we don't top up your oil inside your knee, all right? Hyaluronic acid is a lubricant that we inject inside the knee, helps to reduce the friction between the cartilage and also help to reduce the inflammation. Why like one chicken, one rooster comb down there? Because that's where hyaluronic acid used to come from, right? We took the rooster's comb, we broke it down, and we extracted hyaluronic acid from there, all right? Thankfully, nowadays, we don't do that anymore. Most of the time, it's coming from bacteria that we use genetically modified bacteria to extract hyaluronic acid from. Hyaluronic acid, quite good in patients who have early arthritis and can help to relieve the symptoms and delay the need for surgery for several years. There you go. Forgot about this slide. But younger patients who have mild disease, we do give hyaluronic acid. All right. Very popular nowadays is regenerative options. Everybody wants to be younger. Everybody wants to be like 18. Too bad I don't know miracle medicine to give you the maybe 18 years old again. But we do have molecules and injections that we can give inside the knee that can help to modulate the immune system. And very often these injections will require us to take your own blood. We spin it down, we process it, we take the useful bits of your serum, and we inject it back inside the knee. What that does is these chemicals and cytokines and molecules inside the serum helps to reduce the inflammation inside the knee. And there is some early evidence that it can help the cartilage to regrow. But that one we akan datang. We wait for more information first. Okay? So those are all treatments or non-conservative treatment and or non-surgical management of knee arthritis. The purpose of doing all these things is to reduce your pain so that you can go and see the next speaker, Marcus, all right, for some physiotherapy. Why? Because physiotherapy is the most important. Doing exercises, training the muscles, helps to decrease the stress and pressure inside the knee so that you can preserve your cartilage for as long as possible. But there will be one day where the pain gets so bad, you sit down and you're saying, Doc, I cannot tahan anymore. I cannot stand this anymore already. I need something more than just what you've given to me previously. And that's where we start talking about knee replacement surgery. Okay? Knee replacement surgery essentially involves the doctor bringing you to the operating theatre, putting you to sleep. We shave away the bits of the cartilage that's damaged, and then we replace the parts that we have taken out with an artificial joint. All right? So we got a piece of metal cap on the thigh bone or the end of the femur. We've got a metal plate on your tibia, which is the leg bone, and then a piece of plastic in between that acts as your new cartilage. All right? So this is a new joint. Everybody, when they hear about knee replacement surgery, has an image like this, okay? You think of your uncle, your Kwong who had surgery 15, 20 years ago, all right? After surgery, they are screaming in pain. They've got 2 or 3 tubes hanging out of them. They cannot walk for 2 weeks after that. And they absolutely hate the experience. I'm quite glad to report that the modern knee replacement is no longer like that. Okay? And part of it is this thing called enhanced recovery. Enhanced recovery takes best practices from the physiotherapist, the anesthetist, from all the surgeons. We stitch them together and we make rapid recovery a goal of our knee replacement surgery. In modern knee replacement surgery goes something like this. Before surgery, you do a bit of physiotherapy, all right? You train up your muscles, you get your knee and your body ready for surgery. You come into surgery on the day of surgery, which takes about an hour and a half. And after that's done, you are walking the same day. Gone are the days where you're lying in bed in pain for 2 weeks, all right? The physiotherapist will help you walk on the same day. No more tubes, huh? No more tubes coming out from your spine, no more tubes coming out from the knee, no more tubes coming out from where you ask your rate. You'll be just like normal, you'll be walking well. Some patients, the young ones and the healthy ones, potentially can go home on the same day. But most patients may stay a couple of days just to get a little bit more physio in, all right? And full recovery for this, for knee replacement surgery is 6 weeks to 2 months. You'll be walking well without any aid. And this is all thanks to ERAS, the enhanced recovery pathway. There are quite a few other advancements in knee replacement surgery, namely robotic surgery. Now, don't think that this is AI or robot doing the surgery for the doctor. No, the doctor is still very much in control. All right. Robotic surgery starts with us pre-planning the surgery using software models of your knee. We get from X-rays or we get from scans. You will create an artificial model of your knee. And then we plan how much bone, how much cartilage we need to shave off. We plan where we need to put our implants. All right. And then this is then transmitted to the robot. During surgery, the robot helps us to put the instruments in an optimal position. But whatever sawing or whatever implantation is still got to be done by surgeon. So no AI-driven surgery for you now. And this is an example of a patient that we did a knee robotic total knee replacement in. Well, we planned for the surgery initially with the real-time data that we collect during intraoperatively. We can fine-tune the position of the implants to give the patient the most optimal outcome. All right, so there is no doubt that robotic surgery is more precise, accurate, and like I said, with information collected intraoperatively that the robot gives me, I can plan my surgery much more accurately. Is robotic surgery for everyone? Well, the truth is, no. All right? If you are older than, let's say, 70 years old, the increased accuracy and precision may not benefit you. All right? Because the truth is, a conventional or non-robotic total knee replacement is already very good. All right? But if you're a little bit younger, let's say 65 or younger, where you want your knees to last a long, long time, Singapore, our men can lift. The women can live till 80, almost 90 years old, and men can live till 85, right? So if you are operating at 65, you need your knees to last you 20 more or even 30 years. So in patients who are very, very young, then a robotic surgery may actually be beneficial to help the implants last as long as that. Okay, so thanks for sticking with me. Very, very quick talk. But let me summarize what I've told you guys so far. We can treat the pain from knee osteoarthritis very effectively. There are multiple agents, both orally and injectables, that we can use. Don't be scared of surgery. All right, surgery can be a comfortable process, so that we can restore the function of your knee, so you can go back to whatever you want to do. You no longer have to suffer when you're going for your cruise holidays or climbing up mountains in Japan. Okay, so I think that leads to the end of my talk. I'll hand over to the next speaker. Thanks for sticking with me, and I'll be back to answer your questions later. Hey, thank you.